Care of the patients with problems of the peripheral nervous system. This audio lecture is being prepared in lieu of class today, along with some few short little quiz questions that will be available and as you learn to just practice your knowledge after the fact to best be prepared for our exam one that will be upcoming. And we can talk about that in our next class as well. So your book gives a good outline of, the peripheral nervous system and how it has sensory and motor divisions. Part of the motor division contains the autonomic nervous system, realizing that it regulates, involuntary body functions. The sympathetic part of that helps us respond to painful or frightening situations and sets our fight or flight system in place, in which our heart rate's elevated, our blood pressure goes up, respiratory rate goes up, and blood is really being shunted to the muscles and the skin to kind of take flight, if you will, and away from the internal organs. And so digestion is usually slowed during that process. The parasympathetic nervous system does the exact opposite of that, and it's considered the rest and digest portion of the nervous system. So you may want to compare those, just if you haven't looked at that lately, just to kind of be aware of those functions. In terms of the way impulses are transmitted neurologically, you have to have acetylcholine and you have to have nicotinic receptors that respond to acetylcholine, and that acetylcholine attaching itself to those receptors then creates an action potential and a nerve impulse is conducted. You're going to see some issues with these two diseases we're going to talk about, that either there is an issue with the myelin sheath that is protecting this process, or it may be that there is an issue at the receptor sites that is creating a loss of action potential being developed. And so I'll quickly run through those, but that's just the backdrop of it. This is a good picture. It kind of talks again about how the immune system can destroy the myelin sheath, and we've seen that in discussion about a different disease earlier of the CNS. But this type of destruction can cause jumping of impulses that don't ever result in a full conduction. Or it can actually slow the impulses way down, making the motor response terrifically slowed or not at all. And so just kind of understanding that backdrop and how the myelin sheath could be impacted is important. This is definitely true with Gullian-Barre syndrome that we're going to talk about first. Because it is caused from a demyelination condition of the peripheral nerves. And it is caused by an acquired inflammatory disease that has a very acute onset. Some of the common sources are infections that are usually preceded the development of this inflammatory process. Usually by about 3 weeks prior. It's very common for when you do your history and physical to find that they have either had a respiratory or GI infection. It is also associated with Campylobacter jejuni, which is a bacterial infection, or a couple of viruses, which is cytomegalovirus and Epstein-Barr virus, Mycoplasma pneumonia, and Haemophilus influenzae. So you have several different sources of infections that are kind of well known to precede this by about 3 weeks, is a very common pattern for this to develop. Symptoms are that the patient will have bilateral muscle weakness and pain. They may notice they're just not walking quite right. And again, it's important to know that this is not one-sided. This is not like a stroke would be. It's symmetrical. And very key to note that Guillain-Barre has an ascending paralysis, meaning that it starts bilaterally in the feet and it gradually ascends with the paralysis going up both of your legs to your trunk and then up to your arms. And it's associated with autonomic dysfunction, meaning that your autonomic nervous system is affected, so your typical breathing pattern is stopped, and you eventually, as this paralysis ascends up your body, your complete breathing will stop, and you have no breathing autonomically at all, and have to be placed on a respirator or ventilator. Again, here's some of the risk factors that I just spoke about. It progresses over hours today, and I'm going to show you some of the breakdown of how that occurs. Again, it's symmetrical, so it's happening on both sides of the body. It can cause problems with respiration, talking, swallowing, and bowel and bladder function, everything all the way up that's autonomic. So stages of Guillain-Barre. 3 stages make up the acute course of this. And this could be very, very long lasting if you look at these parameters. The acute or initial period can be 1 to 2 weeks, and it starts with the onset of symptoms until no further deterioration occurs. So essentially, within the initial period or acute period, you are going to get to whatever level of full paralysis that you are going to be in. And often that is full paralysis with no ability to breathe on your own. Next, you reach kind of a plateau period where nothing really happens much for a few days to up to a couple weeks, and you're kind of staying the exact same. And then you begin to get into a recovery phase that can go very gradually over 4 to 6 months. So imagine how lengthy this is to come back into physical capability. And what it is thought is that remyelination and axonal regeneration is taking place during this lengthy period. Some patients get to more like a full recovery, while others have permanent neurological deficits. And when after the recovery phase, nothing else is kind of coming back and it's pretty much stabilized, then that is considered chronic Guillain-Barre syndrome. How do we diagnose Guillain-Barre? You will look at cerebral spinal fluid protein levels, and those will be increased during after 1 to 2 weeks of the illness, and that will increase and peak at about 4 to 6 weeks. White blood cell count is usually increased early in the illness, and that's thought to go along with the previous infection, along with this inflammatory process that's going on. Electrophysiology studies, or what you may hear people call EP studies, can be done directly on the peripheral nerves to demonstrate that demyelinating neuropathies have occurred. And of course, when you finally reach to the stage where the paralysis moved up and you have complete respiratory function failure, you're going to have severe gas exchange problems, oxygenation is going to be poor, and you're going to have to be placed on a ventilator for support. So The main therapies for this is intravenous immunoglobulin, or IVIG. You may hear people refer to that. And it's about as effective as plasmapheresis, which is another method that we've already talked about in class. I'm going to show you a picture of that for better visual understanding. Of course, the priority nursing care is similar to the things we've already talked about for patients that have spinal cord injuries, because respiratory care is paramount. Patients may have a little more pain with this particular disease. Communication is a key issue as well because of lack of swallowing and sometimes speech and throat control. Emotional support is a lot to kind of go for this long period of time where you can't really manage anything at all on your own and be completely dependent. Nutritional support, again, you're on the ventilator with this disease most of the time, and so you're not, and if not, you may have swallowing issues as well that take some time to come back. And mobility, of course, skin care, all the things that typically go along with paralysis is all the same here as it has been with the other patient diseases we've talked about. And again, it requires a whole team effort, involvement of family, lots and lots of education to kind of prepare people for what they have to do with this. Plasmapheresis that we talked about already helps remove circulating antibodies that are assumed to be causing this disease. Plasma is selectively separated from the whole blood, and the blood cells are returned to the patient without the plasma. The plasma usually replaces itself, or sometimes the patient may be transfused with albumin. And the biggest thing here is you can see what kind of a machine. Usually they're using a shunt or a central cath that is high risk for infection. So again, taking significant precautions around that process while it's ongoing are very important to prevent infections. All right. The last thing that I wanted to say, and I'll move back up here just briefly, when we talk about the recovery phase with Guillain-Barre, you have to think about it is an ascending paralysis, but when function begins to return, it is the opposite way. So when you think about, it's going to then kind of subside and descend when you're in the recovery phase. So, you know, if in the ascending phase you have sensation issues and function issues in your feet, and it gradually comes up your body, up your trunk to your lungs and your respiration and your throat and your swallowing, then what is going to start to return first, it is going to gradually descend, is the normal pathway. So respiratory capability would often be some of what first returns, and then gradually over many months you may get more and more rehab and physical capability moving down back to your feet. So just kind of think about it ascending on the negative side and starting at your lungs and descending during the recovery phase. And I'll stop this segment here and do another one separate, just so are shorter clips related to the next disease of myasthenia gravis.